Well, why don't we go ahead and get started because we have several people on the line. In addition to all of the University of Kentucky staff, there is the man of the hour, James, and Lars is listening in while he's driving. Deborah Kim is on the line. David Eisenman is on the line. Is there anyone who I didn't mention? Okay. Well, thanks to everyone. I have a feeling that there'll be some folks joining us here shortly. Let's jump into this. Here's our agenda for today. We want to talk about new or revised constructs and measures for 2017. And then we have a presentation that James is going to go through some work that he did maybe a couple of years ago now, where he looked at several of the national preparedness and health security frameworks to identify gaps between the National Health Security Preparedness Index and some of these other major national frameworks. And then there are some other, that exercise in itself might suggest some gaps where we would want to incorporate additional measures. I know that Chris Nelson also has gone through a similar exercise, and we'll look and talk about that a bit. And then we want to talk about a couple of other categories of measures that we think are important that we need to bolster for the next edition of the index. And then any other that the members might identify. And then a couple of important dates there. Call for new measures deadline is October 18th. And then something that we're calling a NHSPI virtual event, and Anna's on the line. She's been taking the lead on this, working with some of our partners on putting this thing together, and it's still being fleshed out. But I might ask Anna to just say a little bit about this virtual event that's scheduled for October 21st. It's just going to be a 45-minute event beginning at 11:15 Eastern Time.
Thanks, Mike. You want me to go ahead and hit that really quick, or you want to wait till the end of the call?
Well, you want to just say something briefly right now?
I'll just say briefly right now, the plan is for this event to happen, as you said, on October 21st from 11 until noon. Content will probably start a few minutes in as folks dial in. It will be a panel comprising several of our NAC members, including scheduled for the panel right now are Dr. Tom Inglesby as moderator, Dr. Steve Redd from CDC will be on the panel as Dr. Nikki Lurie is scheduled to be on the panel as well. Dr. John Wiesman from the State Health Officer for Washington State. And then representing the PMO will be Glenn, and representing RWJF will be Alonzo Plow. We will be sending around information and materials in coming weeks promoting this event, which is being managed by RWJF and its communication contractor, McCabe Message Partners. We'll send those materials around. We would really appreciate it if the work group members could help us disseminate those materials to your colleagues and stakeholders who might be interested in attending the event. And I'll just leave it at that. Thanks, Mike.
Okay, thank you. And we'll be sending out more information about it. I think that the thing now is just to kind of give you all a heads up so that you can maybe put that on your calendars. All right, so James, I'm going to turn this over to you now, and we can move the slides per your direction. Sound good?
Sounds great.
Go for it.
All right. Well, thank you, everyone, for joining the call, and thank you to Mike and Glenn for asking me to go through some slides that I had sent a while back, but I think the timing is right given the annual meeting that we had over the summer. So this first slide that I have here is just an overview of some of the work that my colleague at CDC and I had worked on back in 2014. As Mike mentioned, it is somewhat outdated and does need some revision of some type moving forward. to look at all of the different frameworks that were existing at that time and how they can align in some way to the index. So we primarily looked at PPD 8, which at that time was the 31 core capabilities within the 5 mission areas. We focused on that from what other lanes within the national guidelines might intersect into what we're calling health security measurement. We looked at the NHSS, which again has been updated since. At that time it was 50 capabilities and 8 categories. Again, broader scope than what we originally focused on from the start, which you'll see is the public health preparedness and healthcare system preparedness capabilities. So that was the 15 and the 8, which yet again are in revision. So that was really focusing on the public health and medical services component of health security measurement. So those are the 3 main pieces that we had looked at relating to the domains and subdomains of the index. But then what we thought we really needed to do was to anchor it and align it with the essential functions for public health, because this is sort of the broad landscape that we started from. We never really talked about it directly, but we saw that, from the resiliency side of the equation, when we were thinking about the index development and whether or not it could be a predictor of how resilient a state or community would be, that it needed to connect to the essential functions in some way, and what was the best way to do that. So that's what we looked at. We looked at it both from a model design perspective in terms of what areas are we missing or might we be missing, or things that we've included maybe too much or in the wrong way. But then also from a communications planning perspective. So how can we best tie this to other frameworks out there to then bring people to the table? And we never fully got to implement that. So that may be something that we can move forward as we look at multi-agency or multi-sector alignment around the index, and using this maybe as talking points or coming up with an interesting way to visualize some of this information or findings as they might get updated. To look at these, we focused on the source material where we could and the definitions that were provided of different groupings of information, whether it was capabilities, the broad categories, our subdomains and domains within the index, the mission areas, that sort of thing. And we sort of did a quasi-blind rating system where me and a few colleagues spread up, looked at those separately, did our own sort of alignment, and then came together to really adjudicate the ones where we were different. So from a methods perspective, it wasn't truly scientific, but it had the essence of that built in. We can go to the next slide. So, like I said, the first step we took was to look at the essential functions of public health. On the next few slides, you will see them in squares that are orange. Then we looked at the PHEP and the HPP capabilities. You see them in similar squares, but they are blue and red. The NHSS capabilities, we did just a smattering of them. We didn't do all of them at the time. Again, they're outdated, but those are the gray circles. The FEMA mission areas you'll see in the arrow, and then we overlaid the NHSPI domains and subdomains that we added because we thought they were missing, or we intended to add at that point, and those are in teal. And like I said, it'll make more sense as we walk through it. And then the recovery capabilities was a late add, which wasn't on that first slide, from the recovery framework, because that came in sort of at the tail end of when we were finishing looking at this. And those are in blue. So that's what we got to at this point. Of note, since then, there was the National Disaster Behavioral Health Concept of Operations that came out of HHS. That may be something that we would want to add on to this. We didn't do it at the time, but that may be another framework to add. And then there may be others out there, but these are things that we were thinking about at that time. So if we go to the next slide, you'll see at the top in the orange boxes are the essential functions of public health lined up. And what we thought was research and best practices, which relates to everything within the index, would be overarching above all of the other functions. So that's how we visually displayed that, because no one could really, everyone felt that it was overarching compared to the rest. You'll see that we put dotted lines down to indicate lanes associated with each of the essential functions of public health. That was more for just a visual, as a visual aid than anything at the time when we were going through this. Again, these are very raw sketches, but you'll get the idea. And so then what we did was we really tried to show within, first with the blue, where the PHEP capabilities mapped according to the essential functions. And again, we did best match. We didn't do it can match here and here and here. We did where's the best fit based on the definitions that we had. And so I'll just point out like an example. Public health surveillance and epidemiological investigation clearly relates to the monitoring and diagnosing and investigating within the context that we were talking about. And so we noted that one there. You'll see, like, for example, information sharing. That is one that was reflected in both the PHEP capabilities, but also the HPP capabilities. And so you'll see that they're mirrored and they're connected because they were intended to be mirroring. And those related to the diagnosing and investigating essential function, but then also informing and educating, whether it's getting information out to providers, to other stakeholders that need to know, and that sort of thing. So we align that there. So that was the first step. Then we put in the gray circles that really represented some, not all, like I said, some, not all, of the NHSS capabilities that were listed in the original. Again, they have changed to some extent and in nature, but we wanted to connect where we could those, again, within the lanes of the essential functions of public health. So, for example, CBRNE, detection and mitigation, to us was related mostly to monitoring, and it connected the public health surveillance capability from PHEP with the public health laboratory testing, and so that's why you'll see it overlapping with those. You'll see that some are stretched out a little bit, but that's just because they really do span more broadly. So, for example, under policies and plans, we had medical material management and distribution that connected directly to mass countermeasures dispensing, which is really an enforcement and providing services capability. And then, but what really overarchingly connected them was the NHHS, which said medical countermeasures management, and that was what they were calling it. But it had the elements of both, and so we purposely stretched them out to show that connection again more visually at that point. Does anybody have any questions at this point before I go on, because it does get more complicated? Can everybody hear me?
Yeah, this is great, James. Thank you.
Okay, no, good. Just wanted to make sure we drop off sometimes.
We're following you right on target.
Okay, great.
Next slide.
Next slide, please.
Okay.
So then what we did was we added in the FEMA mission areas. And so we tried to take the definitions of the FEMA mission areas. The one thing we had to create was sort of an overarching that really just reflected the goal versus the different mission areas, and plotted them again in accordance with the essential functions, but then we looked below them to say, does it make sense from the capability perspective? And so you'll see it goes from prevention to protection, mitigation, then we have that overarching category, response and recovery. And again, this ties into not necessarily recovery from the FEMA perspective, but within the FEMA perspective, what is it that public health really talks about? And so from an essential functions perspective, we talk a lot about evaluation and improvement moving forward. It really, from a recovery perspective, that sort of, if in a true world this visual would have showed it wrapping back around to monitoring, because you go back into that monitoring cycle, visually it was too complex, so we kept it linear. And then also even the workforce and the workforce development needs and rehabbing of the workforce within an event or after an event or something like that. So that's where you see it overlap in that perspective. But then when you look down, again, you'll see community recovery and health system recovery, which both talk about components related to the evaluation improvement, and probably actually could move over a little bit in terms of workforce as well. And then that was really captured within the risk assessment capability of the NHSS. But again, you'll see we also overlap responder safety and health within the workforce, which does also fall under recovery if you were to actually draw a straight line, because there is that connection to those capabilities as well, just not as strongly as the ones that are directly underneath that category. So again, like I said, this isn't a perfect science, but it really, in our mind, helped us understand some of the relationships. When we did this, we took not only the mission areas, but we looked at the capabilities within those mission areas. We knew if we were to put them on top of this as well, it would get even more complex. And we said that's visually, it's just going to get way too overwhelming, and we knew we were already stretching it as it was. It would be an interesting exercise if someone were to want to add those in moving forward, but like I said, we had not. We can go to the next slide.
Hey, James, this is Jackie Scott. How are you?
Hi, Jackie.
So when you put the FEMA mission areas on top of it, I think that complicates the situation, and from spending the last too many months in Flint, going through the Flint water, now recovery, I don't think it actually fits for public health at all. The FEMA mission areas don't fit for public health in general. You're talking about security and preparedness. I think they don't fit. Recovery for public health is a different beast totally, because it's not economic. It's not really, certainly it's about community resilience and restoring the community, but in a different way. So I'd love to have this discussion across across public health preparedness as forward with what we've seen, but I think it really, the FEMA part of it really complicates what we need to do for health security.
So I wouldn't disagree with you one bit in that, and you'll see that sort of reflected, I think, in 2 slides. So keep that thought, because I would like to revisit it.
All right, I'll stay open.
All right. So then what we did was map on, at the time, again, these are outdated because we've changed the names a little bit, the NHSPI domains that we had created, and what that encapsulated within the mapping that we had done. And so you'll see that, for example, the health surveillance domain, which is now health security surveillance, incorporated really elements of all of the items that we had really identified under there, from the public health surveillance and EPI perspective, EPI surveillance and investigation, CBRNE detection, lab testing, and public health lab testing. So from all that perspective, we had that. We had a little bit of information sharing in there in terms of with the lab. I'm not 100% sure all those measures stayed at that time, but when we originally looked at it, we did have a little bit of it. And so we did that throughout, and again, this is sort of just our best way of capturing this. You'll see that pre-event community status at the time, which no longer exists, was on either end, and that sort of stands out, especially to what Jackie said in terms of it didn't really fit with where we were, and probably still doesn't today within this actual framework with the mission areas. It does fit within the rest of the landscape, but again, I have sort of a concluding thought on that. I think it's the next or the one more after that. But then you'll see that we included community planning and engagement, and really it did incorporate the community preparedness perspective, the healthcare system preparedness perspective, public education, volunteer management. Those all got grouped sort of in some of the same places. Incident and information management is sort of the slanted circle, as well as surge management, because it does cross over more of the essential functions than some of the other ones. But in general, when you look at this just carte blanche this way, we had a pretty good coverage of what we thought or hoped that we would incorporate from other frameworks. So that was a positive. You can scroll forward again. So now this next thing that you see, we added the teal boxes, and those are subdomains that we had included or intended to include from the index that were not necessarily representative of a different framework anywhere else, but we were creating it. And so the first one that you see is the environmental and biological monitoring that we created. And that makes sense, and we put it specifically where we did because it looked at sort of a little bit of the surveillance and public health lab testing perspective, but really targeted and honed in on the CBRNE detection and mitigation, which is something that, again, at the time, we didn't really have represented as much as the other two, which we knew. But we thought that that, again, would bring in a little bit more multi-sector engagement. You'll see some of the same things with utilization and effectiveness within our countermeasures. That really relates to the countermeasures administration that you see in the NHSS, as well as some of the non-pharmaceutical interventions pieces, if we were to actually look at compliance and other things in that, of that type, which again, we didn't have measures for that at the time. So that's sort of what we did for this, and we added the other domains. But then what we looked at we looked really at it for gaps. And so we felt at the time, and I think it came up again at our meeting, that information sharing across sectors may still be an area that we could improve. And that could go along with some of the utilities perspective potentially that we talked about, as well as you'll see the circle over environmental and occupational health that is blue compared to the green. We knew we had more work to do in that domain and subdomains moving forward, and we have made progress on them. At the time, we looked at decontamination, air, food, and water security. We did start to get there. You'll see that that one specifically doesn't map to anything else really that we had from a framework perspective. We had recommendations to continue looking at human, environmental, and animal decontamination, but from a hazmat perspective that would tie in other sectors at that time. And then I think if you flip to the next slide, it's the last. And the big gap, and the big, I would call it the eyesore, that thing what Jackie was talking about, is this whole idea of recovery. And what does that mean? And how do we make it fit if we want it to fit? And do we say it doesn't fit within the index? And so when we looked at it, that was sort of our recommendation for a gap or exploratory phase and how you engage other sectors. So for example, from the NHHS, within the recovery pieces, there was a lot about health and social services and housing. We hadn't really thought about that, and we hadn't really put that in. We did it a little bit now with the built environment, but again, you'll see that still overlaps with the environmental and occupational health pieces. But that was something that, again, how does that fit into the public health piece? The same with infrastructure systems, community planning and capacity building, especially so that could be the economic development pieces, that could be the resiliency pieces after a disaster, or building that before. Which really, again, shows that the recovery piece is connected to the prevention piece and the monitoring piece, or at least in our thought process it was. Economic recovery, and then at the bottom you'll see natural and cultural resources, which gets into the environmental pieces that we haven't really thought about. But again, when I looked at this and I saw what we had talked about at the last in-person meeting, I was like, we talked a lot about utilities. Well, is that really what we're talking about with infrastructure systems? You know, some of the pre-event community status pieces that we said, well, it would be great to still incorporate some of them. Are we thinking about that really from a community planning, community development perspective? And then really we hadn't talked about the economic development or economic recovery perspective. So does that fit in this context? So that is what we had done to this point. I am happy to answer questions. I am happy for someone else to say this is a good start. We need to take it forward. And I'm happy to debate the recovery piece with Jackie and our other colleagues because it was something that we recognized at the same time to be a little bit or very nuanced, I guess.
James, this is Lars Powell. I wonder if I could ask a question. I don't have the benefit of seeing your slides, but can you just give me a quick idea of what it is about recovery that doesn't fit in with public health? I'm not coming from a public health background, so I'm claiming this is my own ignorance and just want to know what we're talking about.
Sure. Jackie, do you want to give your example specifically from, just because your issue at hand in Michigan is real time? If not, I can talk a little bit in some of the past or historical pieces.
I'll talk a little bit.
Okay.
If you talk about classic recovery, certainly bringing the community back to pre-event status or better than pre-event status, it becomes primarily economical. So for example, in Flint, and I'll just use Flint because we're in the middle of it, we're fully moving into recovery, and the big pushes are targeted case management for children, behavioral health services for children. So we're moving through a recovery phase that will probably take, Medicaid coverage up to these kids up to 21 years of age. So we're going to have years of recovery that become and move into the programs as if they're part of our routine work. So we approach a new normal with public health recovery. It's nothing that you would think of in terms of the classic FEMA recovery capabilities and capacities. So it's really new. What we're finding is we're defining public health recovery that for us, and public health preparedness is especially new, that every time we have an incident that we move into a new normal with the activities from that incident into recovery on top of our daily activities. So we're still working on Ebola. We're adding Flint behavioral response, behavioral health, programmatic lead issues, water issues, providing volunteers on top of our daily preparedness responsibilities that are really recovery ongoing. So how we define those, we're working hard on that, but it's different than anything that I've ever seen in the past related to your classic recovery.
And I would jump in just to say I completely agree with that, because what we've experienced here in Rhode Island and what I've seen nationally is that from a recovery perspective within public health, it is truly that integration or quality improvement of systems and response needs that worked well, and then how do you incorporate that into the routine operations, basically improving your basic level of monitoring, diagnosing, and investigating, informing and educating, mobilizing and managing, not just things like direct assistance, IA or PA or anything like that, which does have a role, especially when you talk about businesses and healthcare businesses and things like that. But then also for those things that didn't go well or didn't work so well, or that you depleted to a extreme, how are you rebuilding those things in either a better way or continuing to address them moving forward, so that, for example, maybe the fact that there was no way for us to vaccinate college students well within our state during H1N1, one of the recovery efforts was ongoing seasonal flu vaccination for that specific population, but also the development of rails, so to speak, of a delivery system to vaccinate more easily that college population. So it's, in my perspective, it's very different, or that perspective of it is very different than the traditional recovery definitions and focus.
Thank you, James, and Jackie, and Lars for your question. I want to turn it over to Chris Nelson, and Chris sent an email here a few minutes ago asking if we could add some information to the presentation, and I believe that we have successfully done that. And can you advise us on?
Yeah, I'm going to go ahead and take this down and pull up Chris's list.
Okay, thank you.
Hey, Mike, and thanks. You guys are awesome, so sorry for doing that on the fly. Actually, before we get into my list, and unlike James's systematic crosswalk, I took a more impressionistic, let's say liberal artsy approach. I looked through the measures, looked through a number of other frameworks, including some work that's coming out of the European Centers for Disease Prevention and Control on Preparedness, just to try to identify some gaps at a conceptual level. But before we get into that list, James, I think you have put on the table the key question here, which is what is within scope here? And I think there are two kind of broad areas where that's relevant. One, of course, is recovery. So to what extent is the National Public Health Preparedness Index, and I underscore the word preparedness there, to what extent should this index focus on recovery, and if so, what would that look like from a public health system's point of view? On the other side, the other issue you raised is the prior community status. What in the national response framework, I suppose, would be more sort of prevention, mitigation, those sorts of things. So before we, kind of get into the weeds of another list, I guess I'm thinking it might be helpful to have a little bit of conversation around that. Is the preparedness index, should the preparedness index be focusing on things besides preparedness and response? And Mike and Glenn, is there anything from the NAC that you think is relevant for us to keep in mind as we talk through this?
This is Mike. I regret, and I know that Glenn regrets, that he had to jump off this call about 5 minutes ago because his boss, the dean of the College of Public Health, requested his presence. And so, unfortunately, Glenn isn't here. So I'm sorry, Chris, I wanted to get that out, and I completely have swung and missed on your question. Could you repeat your question regarding the NAC?
Yeah. I wonder if we have any guidance or input from the NAC on the extent to which the National Public Health Preparedness Index should be focusing on pre-event community status, what in the NRF would be prevention, mitigation, and then on the other side of the continuum on recovery. So we could imagine the index trying to focus on everything, sort of a snout to tail, if you will, from prevention to recovery. We could also imagine, and I think this is sort of where the index has been historically, imagine that the niche of the index is more on preparedness, and response. And so
Right.
I wondered if we have any sort of guidance or any input from the NAC on that, or is that a closed issue, or where do we stand on that?
Well, so I'm going to say my piece, and then I'm going to ask Anna to weigh in on this. A year ago or so, we collected the data from the so-called Cutter Index, which many, if not all of you, are familiar with, which is a county-level index that is designed to measure the resiliency of counties. And so we took that same framework. There were, I think, about 55 measures, most of which, all but about 2 or 3, translated very well to the state level, and put them in a new domain. In this case, in the context of NHSPI, would be the 7th domain. Created about 5 or 6 subdomains that we call pre-event community status, and these were things that included things like the educational level of the population, some of the socio-demographic factors that we would associate with enhanced resiliency. There were some infrastructure measures, some housing measures, and that was presented to the NAC in October, so just about a year ago, as a possible set of measures to include for what became the 2016 NHSPI. I did not attend that NAC meeting. Don't actually recall exactly why the NAC decided not to bring those measures on board. And so at this point, Anna, if you're still there, is there anything that you can add to this discussion?
Absolutely. The pre-event community status domain that was sort of stood up last year, if you recall, and during the public comment period, there was the publication of the document of some recommended changes, and that was among them. The issue that arose there was really a challenge, in both computational and philosophical, about how to include vulnerabilities in a capabilities-based index. And when you looked at the kinds of measures that were proposed for that pre-event community status piece, there were a lot of vulnerability-facing kinds of issues, which became a real computational challenge. To address the broader question of this longer-term recovery resilience, is the index and everything in the kitchen sink sort of approach? Well, the NAC has engaged in a number of discussions around that issue, and I can't say that we've heard them come down firmly in any direction. I think there's a recognition that the more we incorporate, the more we need to think about the communicative challenges of ensuring that we are being very clear about what we are and are not measuring, because as you begin moving more and more toward resilience focus or a recovery focus, you can sort of get some confusion going on there. However, that sort of issue is inherent in the index itself in many ways, because those words health security are also in there. So you have not just the preparedness index, but it's the health security preparedness index. So health security sort of implies in and of itself pre-event community status. It implies levels of resilience. It implies a number of areas that we don't fully dip into yet with the index, but might be exploring in the future. So the answer is a solid maybe on all of that, Chris.
Okay.
And this is James. I would just add that one piece of information I remember from back when this first was introduced was actually sort of the contrary in terms of, should we be including any response-related measures in the sense, or response and recovery measures, because should this really be about the preparedness piece, which should be predicting the response and the recovery? And so I would just throw that out on the table as well.
And I think, James, that, oh, sorry, I was just going to say that also points to something that we have raised with the NAC, that and that I know James is familiar with, and I know that Jackie is on the phone, and she could probably speak to this as well, that we have heard from some sectors, and including the public health sector, about concerns that the word preparedness implies a more narrow focus and a more narrow field of responsibility and responsible parties than perhaps the index should.
I think everybody uses preparedness now, so it's not preparedness that would be limiting if you talk about public health preparedness, and that does change it a little bit. But in the discussion we're having, there's really no good measures. They really don't exist for health security preparedness. There isn't a good measure for that. In fact, when we asked for technical assistance from HHS, federal HHS, about recovery, and really all they could do is to go through the dog and pony show that everybody has from like a ConOps. There's really no materials even out there for recovery. Very few publications from any sort of incidents that have occurred that clearly talk about recovery. So we can talk about it a lot in terms of the index, but we're not going to find measures to really assist us moving forward. I think we can almost take it off the table at this stage because of that. But on the other hand, the pre-event status, I think, is critical to how a response goes.
James, just to be thanks, Jackie. James, to be really clear, when you talk about a response measure, are you talking about measures of how actual responses have gone, or what do you mean by that?
Both. So in some instances, which we don't really have yet, in terms of how well an incident would happen, or predictors of how a response would happen for a specific type of scenario, which we had talked about at one point, which would be one category. But then others in terms of proxies that we put in as measures for response. So if you have a high rate of seasonal flu vaccination, is that sort of a response proxy for an emergent influenza vaccination and other things of that nature?
Got it. Thanks. Okay. So Jackie makes a case for taking recovery off the table, but leaving pre-event community status on the table. Other thoughts about that?
Well, I've got kind of spotty cell service, so I'm going to try to say this before I get to the bottom of the hill. I think that the recovery is similar to what we talked about in Santa Monica with having some rather than a hurricane or recovery would fall into the same category. There's not much you can do to prepare for it, but depending on which industry and what employers are prevalent in an area, different areas are going to recover more quickly because there'll be more economic stimulus from that employer or those industries or whatever the demographic factors might be. So if I'm not saying this is the reason to include it, but that both of those things would have the same, would be in the same context of, are we concerned with things that we cannot control or not?
Okay, great, thanks. And Julie, you just typed, does community recovery relate to community, or how does recovery relate to community resilience? Do you want to say anything about that? No, Julie's still typing. Other thoughts?
Well, recovery is really building back community resilience. And recovery is huge. It's very, very important, and it really starts from the time an incident begins. You have to start with the recovery process to get them back. It's all integrated, and I think that this is kind of my pet peeve, I think we've really tried to define mitigation and response and recovery and be very clear, and it fits in these categories. And when you're talking about incidents involving health, nothing fits in those categories really well. They're all overlapping. So for us to try to, for the index, at this stage, take recovery and put in measures, I think it'd be very difficult. Not that we shouldn't continue to look for recovery measures and define and put it in the parking lot, and that's certainly a goal. My goal is to contribute to that in terms of Michigan status when I can finally publish. But that I think that it is critical, but there's really nothing, I don't think, I mean, maybe somebody's better at finding things than I am, but there's really nothing out there for us to put into the index at this stage.
And for example, just to piggyback on Jackie's point, I think like a good, and this is not the optimal measure, but just to conceptualize this for folks, at least from our perspective, I think, and Jackie, correct me if you disagree, but I think you may agree, like a measure for recovery that would be great from a public health standpoint, or maybe even from a FEMA standpoint that does not exist, is the percentage of a state's corrective actions and improvement plan items that are identified for all events in a year that are then corrected by the end of the next year. And continually resetting that and figuring out what the target should be and all of that. But that's the recovery piece. That's the integration of the activities from the beginning of the event to the end of the event that happens. And that would be like, for example, one of those measures that I would actually say if they had that, then yeah, we should at least put that in for recovery. But we know that doesn't exist, nor is it standardized statewide.
So we have a bit of a kind of a long-term, short-term issue here, and Jackie, you sort of alluded to this. Our deadline for proposing new measures for the next index is coming up very quickly next month. Does anybody want to make a case for trying to push any further on recovery or pre-event community status for the next index, or is it something that that we recommend be put on the table for the index after the next year?
Well, I think the pre-event community status is important. I can see why it's a tough nut, but when you talk about the economic status, the housing, let's say water quality, the basic public health programs, whether they're implemented or not in the community, is huge when you run into an incident. I'm a true believer in that. Whether you can get the NAC to support that or there's enough measures, I think you can find measures, but it might make a few preparedness directors a little queasy to see what it looks like in their state.
Yeah, this is James. I don't think that you can talk about national health security without talking about national health equity. And I think it gets to that same point, and that's the pre-event community status. And I don't think that you can exclude that.
So I can imagine, we can talk about it and we can measure it. Measuring it seems like pretty tall order for the next month. To what extent? I guess I haven't noticed much discussion of this issue of pre-event community status on the website. Is it there and I've not noticed it, or is that something perhaps that we should consider adding a stronger narrative around to frame this index?
Chris, I know that a year ago, I believe that, and Anna, if you're still on the phone, you please embellish what I'm about to say, but something that came out of that meeting was, look, let's not use it in a computational way, but let's keep these measures, this framework, this construct that the Cutter Index provides, and that we're calling pre-event community status, and let's put it on the website and make reference to it. Let's create a narrative, like you just said, that acknowledges that, look, we understand that this is very important, but at this point, we haven't quite figured out the best way to, incorporate this in a way that we're happy with. Anna?
Yes, that's exactly what the discussion was last year, Mike. It was around how we can connect to the Cutter Index and connect to measures of equity without yet standing up this pre-event community status. And part of that is in communications and pointing to those materials, and part of that is in doing secondary analyses and other work to make sure that we start detecting some of the relationships. But I know it's an area that we'd still like to see how we could integrate it eventually. It's just that the measures and the domain has stood up last year really was more vulnerabilities focused than capabilities focused, and this is the models and methods group. So if you can figure out computationally how to incorporate that, we can always, I think, revisit it. But in the meantime, yes, that's what we're doing, is we're pointing folks to Cutter, we're pointing folks to other pieces. We're also going to be launching the blog function on the website very soon, and hope that will be an opportunity. Maybe James would like to write a piece about the importance of thinking through an equity lens for preparedness, even if we're not able to stand up that domain in the next year or so.
Yeah, that's a great point, Anna. I mean, we talked about this morning before this call. And so we're looking to put some new material on this yet to be launched but soon to be launched blog function on the website. Some new material about every 2 weeks, and so we've got a few things. I think we're good for about a month and a half, and then we're going to start looking for some new material. So to the extent that any of you are interested in writing a short piece or doing something that and you'll be able to see once we get this thing rolling, sort of the nature and quality and length and so forth of what we're coming up with. And so once you look at that, that might inspire you to create your own and send it in more than likely we'll end up using it.
Mike, since you had collected and looked at the ability to aggregate on the state level the Cutter Index before, would it make sense or is it feasible to take that within the components of the Cutter Index, assign each of the components to the most relevant domains within the current index, and add those in and do a few analyses to see whether it hurts or enhances the index?
Yeah, we could certainly do that. As a matter of fact, we collected the data. I mean, I collected, I and a group of folks that I had working with me, the data for all of because it was my anticipation that we were going to be using it. And so the data exists. We could do what you described. I will point out that I believe that Glenn did kind of a simple, scatter plot between that data, the Cutter Index, because it was also part of the Delphi. If you recall, when you participated in that, many of the folks here on the call today who participated in it, we included the pre-event community status, which was, the Cutter Index. So we've got the Delphi weights, we've got the data. Glenn did a piece that, back in the spring that looked at the relationship between the Cutter Index or the pre-event community status domain and the index scores. And yeah, I don't even remember exactly what that relationship looked like. I think just about everything that Glenn looked like, correlated very well. Had a nice looking scatter plot when matched up to the NHSPI scores. But we have about 5 or 6 minutes left, and so I want to try to adhere to our schedule here. And so, Chris, I just mentioned that we've got your list up here on the screen if you want to point to that.
I'm not going to spend much time on it, but as a matter of process, Mike, my understanding is that this meeting we're trying to kind of get some of the issues, some of the potential gaps on the table. When we meet again in October, that's going to be just before the deadline for new measures, right?
That's correct.
And so I think what we would like folks on these committees, both model design and methods, both represented here, to think over the next couple of weeks and send emails with ideas for new measures. And then we can collect those ideas, discuss them at the next meeting before the window closes. So very briefly, and Mike, maybe we could share this around. Again, I went through and in a somewhat less systematic way identified some constructs that maybe or maybe not can be measured, but maybe worth thinking about. One is sort of gets to pre-community status, but it really had to do with to what extent and I have no idea if they're measures, but are there efforts to be aware of vulnerable populations? I'm thinking about people who are electricity dependent, they have home ventilators or something like that. Infection control and treatment guidance to clinicians. I didn't see much about that. Again, not sure how to measure it. Plans for families of first responders, which we know has something to do with their willingness to respond. Mechanisms for, and this is a little bit wonky in the wording, but state and local interface. So states, with a few exceptions, get the funding, but often, preparedness and response are at the local level. And so are there clear mechanisms in place for states to communicate these requirements and support the locals? Business preparedness. That is a strong theme in the NHSS. Maybe we're thinking about recovery was meant to be a separate line, and we've already discussed that at some length. Another one that has sort of come up that is a strong theme in the NHSS is the notion of continuous testing and improvement. And so we have some measures currently in the index that are based on drills or exercises, but is there some way to get at, as James was saying, the ability of a system to actually use the lessons learned to improve systems? Another thing that was in the NHSS that maybe is worth brainstorming about is the notion of making best possible use of existing resources. The NHSS, for instance, defines as one of its principles leveraging opportunities in one area to make advances in others. Dual use, multi-use. Again, not sure how to measure that, but just in the spirit of brainstorming. The public health aspects of mass care, the SF6 stuff. So that's sometimes kind of a tricky thing to nail down. It might be provision of medical services and mass care sites, mental and behavioral health, surveillance. That's something that I'm not sure that we're getting at. And then the decon piece, we have that from the lab testing point of view, but we really don't seem to have that from other points of view, from field response points of view. And as we know from like the Boston bombing, even though there were no decon issues, that is a critical capability to be able to make that determination. So those are just a few additional things in addition to James's ideas to put on the table for brainstorming. Mike, I know Glenn had shared during the Santa Monica meeting another list as well. So I know we're just about out of time, but is it worth mentioning that, or should folks refer back to the slides for that?
Let's see. We'll go ahead and I'll march through it very quickly. It looks like Ann is bringing up the original presentation, and I will email, make sure that list, Chris, gets emailed to the entire group that you just had on there. Okay, great. Thank you, Ann. Okay, so individual levels of preparedness. So we were looking at a couple of different ways at getting at this, really two. As you know, the behavioral risk factor surveillance system has a module on individual level preparedness, but very few states actually use that module. And here you can see that really in 2012 only 2 states did, and then again in 2010 only 2 states did too. FEMA has a survey that they field periodically. I believe it used to be every other year. I'm not sure about that now. It might be annually, but the last one was just released this past summer, and it was conducted in 2015. I actually reached out to some folks at FEMA and haven't heard back from them yet about the possibility of getting the actual survey, the microdata, from which hopefully we could figure out a way to generate some good state level estimates that were valid. And so we're still working on that. And these would be the kinds of things like, do you have a plan? I used to live in Los Angeles, and we stockpiled water and a little bit of food as a kind of a preparedness in case of the big one, the big earthquake. And so questions that are designed to really get at the level of a household or an individual, that would be something that we're looking for now. So if you know of points of contact at FEMA, or if you know of other data sources where we can get to this, that these kinds of measures capture, send me an email and let me know. The other big area that was brought up both in Santa Monica and that Glenn has mentioned that he thinks that it's his sense that we need to really include more of, is in this area of occupational health. The bullets indicate some of the big points that were brought up in Santa Monica. And so you have that here, and you also had it in the minutes of the of the July meeting at RAND. Take a look at that, and again, just to repeat what Chris said, the deadline for new measures is in about a month. It's October 18th, and we're going to, this week I think there'll be a button or a link on the NHSPI website. We'll be putting out a call to far and wide, requesting folks to send us new measures. We particularly want to hear from you, the members of this work group, based on what we've talked about here, and then anything that you didn't get a chance to actually, say your piece on, please send it on, and we'll share with the group, or at least we'll have it. And if the wider work group thinks it's a good idea, then that's what we'll advance to the NAC. Chris, that's all that I have. Is there anything that you want to add?
Nope, I think that's it, and we're out of time, so that's perfect.
Okay. Well, okay. Thank you, everyone. Very much appreciate your time and input and patience. James, a special thanks to you.
Thank you, everybody.
Anytime. Thanks, guys.
Bye.
Bye.
Thank you. Bye-bye.